Thank you very much, Dr. Wang, for the very kind introduction, and also to the organizers to invite me to speak in this meeting about the inflammation in HIV. I'm really excited to be mentally traveling to share thoughts with Asian colleagues. So let's go ahead. This is a disclaimer. And these are my disclosures. So why talking about inflammation in HIV in 2021, 40 years later, the first identification of AIDS cases? Because the clinical priorities have likely evolved in HIV. From a medicine, first based on symptomatic and palliative care in the first years, to the years of dealing with suboptimal ART efficacy, virological failure, drug resistance, and toxicities, to the simplification of therapies more recently. And now we are at the point in which we are trying to fully normalize the health of and quality of life of people with HIV. And in this last objective, inflammation is a key actor. And that's why provocatively, our French colleague Pierre Corbeau has suggested that HIV acronym should stand now for human inflammatory virus. So first of all, I'd like to address the causes and biological significance of inflammation on people with HIV who are on ART and have undetectable viral load. So in untreated patients, the main driver of inflammation is HIV replication. Once HIV replication is controlled by ART, inflammation is multifactorial and an incompletely understood phenomenon. So an important question on inflammation is what's the role of each cause or each of the factors implicated in it. Some of these factors are actually associated with the risk of HIV acquisition, and these are the lifestyle factors, but others, such as those represented in this figure, are rather a consequence of the untreated infection, such as ongoing low-level HIV replication or bacterial translocation, which occur despite plasma viral suppression. And some of the factors affecting inflammation are long-lasting consequences of acute HIV infection. For example, inefficient CMV control reflects persistent T-cell effects that seem to have a major effect on immune senescence and mortality, as suggested in this Italian cohort where CMV IgG positivity showed individuals with IgG against CMV had higher risk of mortality than those who were seronegative. But we don't fully understand each part of the problem. For example, damage in the gut barrier is one of the contributors to inflammation during HIV by allowing translocation of bacterial products that trigger inflammation. But within the mucosa, many independent effects contribute to bacterial translocation, including enterocyte apoptosis, Th17, CD4 T cell depletion, regional lymph node fibrosis, and changes in the microbiome. And ideally, we will need to correct each of these defects to solve the problem. And we even have novel factors poorly understood yet. And the microbiome is one of them. The microbiome is influenced by lifestyle factors associated with HIV acquisition and is also a determinant of inflammation, since it is possible to reproduce the distinct immune phenotypes of different populations of people with HIV by stimulating blood cells in vitro or doing fecal transplants to mice with the fecal bacteria from the patients, as showed in these studies on the left and on the right. A very interesting and controversial area is the role of viral persistence during ART in tissues. So in patients on ART, more than 95% of proviruses in the peripheral blood are defective. Historically, these defective proviruses have been thought to be dead-end products with no real pathophysiological significance, as they do not encode replication-competent viruses. So there is continuous production of defective viral proteins that, while cannot induce new rounds of infection, are biologically relevant as they are sensed by the immune system and can elicit immune activation. And this phenomenon in lymphoid tissues occurs despite very early ART, as shown in individuals sampled during acute infection here on the left, and after 1 year of ART, indicating that viral production is not dependent on the existence of severe immune damage. And this is one of the studies done by Tim Shaker's group, who has focused on this question. And very remarkable is the work on the right done by Angela Kashuba's group in mice, in macaques, and in humans, where they find that up to 90% of HIV RNA, showed here represented in green, is expressed in tissues where locally there's no exposure to drug, which is represented the drug concentrations here in red. So you will see the virus in green, where there's no drug in black. So these data argue that there are gut and lymph node regions with little to no exposure to antiretrovirals, which might result in low-level HIV replication, contributing to HIV persistence and inflammation. Another very compelling piece of evidence that supports that low drug levels in tissues can result in increased inflammation is provided by the set of works by Jose Castillo Mantilla in Colorado, where across different cohorts of virally suppressed patients, a correlation between lower ART adherence and higher inflammation is established. So how could adherence impact inflammation in subjects with undetectable HIV RNA in plasma? The most plausible explanation is that by allowing low-level HIV replication in sites where drugs are distributed less well, especially when adherence decreases. And this seems to have clinical implications, as suggested by this recent study in nearly 7,000 suppressed patients in the Swiss cohort, in which adherence was measured through questionnaires. And interestingly, non-cardiovascular related mortality showed statistically significant increased risk with missing more than one ART dose, suggesting an important role of ART adherence on inflammation and the risk of adverse clinical outcomes. So this study leads us to the next question, that is this clinically relevant? So it is often argued that inflammation is not relevant as a pathogenic mechanism in treated HIV. So let me show you some data. Outside HIV, inflammation is a major determinant of age-associated diseases, such as a cardiovascular disease or some cancers. And this phenomenon is commonly referred to by the term inflammaging. And this is only one example on the left, psoriasis, a pro-inflammatory disease. Here, inflammation in this study was measured in plasma by the CRP or D-dimer concentrations, and these concentrations correlated with the presence of atheroma plaque and aortic inflammation. And similar findings are appreciated in HIV on the right, justifying the excess risk of cardiovascular events appreciated in these patients and not explained by traditional risk factors. And these are beautiful mechanistic studies using PET scans, but also similar ideas are suggested by a whole bunch of experimental, epidemiological, and also clinical studies. So there is compelling data indicating that inflammation is a pathogenic driver of a wide range of conditions related to aging, including not only cardiovascular disease, but also very different illnesses such as cancer, diabetes, or dementia. And importantly, the effect of inflammation is not necessarily organ-specific, since it has been shown to affect health very broadly, as for example, increasing the risk of frailty. And these associations occur in both the general population and in people with HIV, in which the effects of inflammation is even magnified. What are the specific facts about inflammation in HIV? So with respect to the pre-infection stage, people with HIV on stable ART show a mean 50% increase of different inflammatory biomarkers. This has been shown in a number of cohorts with a very reasonable control of potential confounders, such as lifestyle factors. So the impact of HIV on these biomarkers is not dramatic. But the impact of these biomarkers on outcomes in people with HIV is stronger than in the general population. In this study shown on the left and performed by the INSIGHT study group, being in the higher quartile of IL-6 resulted in a fourfold increased probabilities of severe non-AIDS events of death 9 years after a single measurement. So inflammation predicts the risk of clinical progression strongly and durably, and this effect is very robust and independent on the extent of immune suppression, as showed by the fact that the size effect of each twofold change increased predicting events was very similar in these two cohorts of people with HIV with very different nadir CD4, low or high nadir CD4s. So among the multiple biomarkers of inflammation or immune activation that we could measure, we have done our best to disseminate the following story because we think it can be helpful. So in 2013, we became very interested in understanding the biological and clinical significance of the balance between the CD4 and CD8 T cells among patients with adequate CD4 counts. And it was shocking to see that in some patients, both the CD4 and CD8 counts return to normal levels, and in other people, the CD8 counts remain higher than the CD4 counts, in contrast to the pre-infection situation. And we found consistent associations between having high CD8 counts and a low CD4-CD8 ratio and increased immune activation and excess risk of mortality. And because the ratio is easily accessible in clinical practice, since then many groups have shown interest for this biomarker and have reported that the ratio is predictive of what we need to predict, that is the risk of non-AIDS events and even fatality or mortality. And we've been able to even find informative cutoffs, and it looks like only people with very low CD4-CD8 ratios below 0.4 or 0.5 will be at increased risk of adverse events. So can this CD4-CD8 ratio replace the classical biomarkers of inflammation, such as IL-6 or D dimers? Probably not. Each of these biomarkers independently contribute to the prediction of clinical outcomes. And that's what Jason Baker looked at in this analysis in the START study, where each biomarker contributed to the risk prediction. In other words, each biomarker reflects different biological pathways that are independently predictive of the risk of death. And when considering the predictive value of each biomarker alone, the ratio explains the risk a bit better than IL-6 or D dimers in the START trial. So inflammation is clinically meaningful, and we have informative biomarkers. What should we ideally measure? So at least for research, we should aim to capture the information provided by biomarkers that reflect different pathways that have been linked with adverse outcomes. And we should measure selected biomarkers of each system, reflecting systemic inflammation, monocyte activation, adaptive immunity, and mucosal integrity, such as those highlighted here, reflecting these independent pathways contributing to adverse outcomes. So if inflammation is clinically relevant and can be measured, we have our next controversial point, which is whether we should monitor inflammatory biomarkers in the clinic or not. And you will have the opportunity at the end of this talk to share your thoughts with us. So first, it is important to note that not all the parameters that we monitor in HIV are helpful in decision making. We have to acknowledge that the most extreme example for an HIV physician is the CD4 count. So we can't break the habit of routine CD4 monitoring, despite that we know that in patients that maintain HIV suppression and in whom the CD4 count is above 350 CD4 counts, this parameter is not helping us any longer to make decisions, as recognized in many publications. So monitoring the CD4 counts in patients on stable ART is already controversial, as it is controversial monitoring the C-reactive protein in the general population, despite the fact that it has been proved that having more than 2 milligrams per liter of CRP identifies subjects at increased risk of cardiovascular events. And in fact, the 2013 American Heart Association guidelines established that measuring C-reactive protein in subjects at intermediate cardiovascular risk, as predicted by the Framingham risk equation, could help in the decision to initiate statins. So if we consider that HIV increases the risk of cardiovascular events, we could argue that this parameter will still be more helpful among people with HIV than in the general population. So what should we measure? Actually, the European AIDS Clinical Society and also locally or Spanish AIDS Society guidelines already recommend monitoring the CD4-CD8 ratio, but not the American DHHS guidelines. So in my view, the CD4-CD8 ratio is an informative biomarker and is already available in most settings. And other inflammatory biomarkers such as CRP or D-dimers can be measured, but are too variable within individuals and have the downside that we lack on also the CD4-CD8 ratio, we lack of direct interventions to improve these biomarkers or direct evidence that ameliorating inflammation improves prognosis. So in my view, what we need is to demand this information as exploratory outcomes in clinical trials. And if we want, we can monitor the CD4-CD8 ratio because it's already available. So the next question is, what's the role of ART on inflammation in suppressed patients? Do we have evidence that reducing inflammation improves prognosis in HIV? So no, with other interventions beyond ART. The SMART study showed that episodic treatment interruption guided by the CD4 count increased the risk of opportunistic diseases or death from any cause, and strikingly also the risk of cardiovascular disease. And this trial linked this excess risk of cardiovascular disease in the treatment interruption group with higher inflammation. So we can argue that ART improves the risk of cardiovascular disease by decreasing inflammation. Similarly, immediate ART after HIV diagnosis with more than 500 CD4 counts caused a reduction of non-AIDS events in comparison with delaying ART initiation until a CD4 count below 350 cells was reached in the START study. And IL-6 and D-dimers consistently predicted clinical risk across a broad spectrum of CD4 counts. And the good news is that after a rapid decay following viral suppression after ART initiation, in different cohort studies, ART seems also able to progressively improve most of these biomarkers during long-term viral suppression. So it appears that some biomarkers of inflammation, at least some, so slowly but progressively improve during long-term ART. Our next question regards the effect of particular ART regimes. And we will have also the opportunity to discuss about this later. So what are the data? Regarding the third drug, we have information from randomized controlled trials arguing that there are differences. For example, in this study from Gerisma-Comsys group, patients who initiated ART with elvitegravir showed a significant higher improvement of high sensitivity C-reactive protein and soluble CD14, a marker of monocyte activation, than those who started with efavirenz. And here, in an analysis using data from the STARMARK study, which maintained the blinding up to 5 years, we found that patients starting with raltegravir also normalized the CD4-CD8 ratio faster than those with efavirenz and the same NUC combination. And we also have data from a real-life setting. And this is a study we have performed in CORIS, which is the Spanish cohort of ART-naive patients. The cohort started recruiting patients in 2004 and already has more than 1,800 patients on follow-up. So here we compare the effect of the first-line regimen on CD4-CD8 ratio recovery after 8 years of ART. And we assessed confounding through different approaches. And the conclusion is that patients starting with integrase inhibitors have a better CD4-CD8 ratio recovery, and this is dependent of not only a faster CD4 count gain, but also on a steeper CD8 decline, essentially during the first year of ART, suggesting that the first wave of immune reconstitution is relevant in the long term. And are there differences in the switching scenario? We see consistent findings when you look at Spiral and Striving and other studies in which switching the third drug to an integrase inhibitor resulted in improvement of several inflammatory markers. So here on the left, in spiral, switching from boosted PIs to raltegravir resulted in a 30 to 40% reduction of very meaningful biomarkers, such as C-reactive protein, IL-6, and D dimers. And consistent findings were showed in a study led by the same author, Esteban Martinez, when switching from PIs to dolutegravir. And what about the effects of switching from 3-drug regimens to 2-drug regimens? This is a very hot topic. So in short studies, participants were randomly assigned to dolutegravir plus rilpivirine, the early switch group, and to continue their standard regimen to then switch to dolutegravir plus rilpivirine at week 52, the late switch group. And at week 100, there were relevant increases of IL-6, soluble CD163, and soluble CD14 biomarkers of monocyte and macrophage activation in the early switch group. And these are recognized predictors of mortality. But there were also milder decreases of VCAM and IFAP, which prognostic significance is less clear, but which have also been linked with mortality. So authors interpreted these changes as neutral. And the 148-week data were presented at last CROI. And at this last time point, authors found a reduction of IFAP and an increase of D dimers in both arms. And because at these later time points, both arms were on the 2-drug regimen, it is unclear whether this effect is due to the number of drugs or not. And Tango study evaluated the impact of switching to dolutegravir and lamivudine versus continuing with TAF-based triple drug regimens. And here, after 48 weeks, IL-6 had increased by 16% and soluble CD14 had decreased by 3% in the 2-drug regimen arm, without differences in D dimers or a C-reactive protein. And these changes were still significant after 144 weeks for IL-6 as presented at last ID week. So, and again, because the opposite directions of this IL-6 increase versus soluble CD14 decrease, these data were interpreted as neutral changes. So these are the data, and because the data are a bit messy, I find that many clinicians tend to conclude that inflammation should be put out of the debate. So let me share my thoughts with you. Inflammation is a complex phenomenon. If you measure inflammation using a wide panel of biomarkers, as we did here, you will find that even the most robust biomarkers in terms of risk prediction are poorly correlated among them. And this does not mean that all these biomarkers are clinically meaningless. Rather, this implies that when you deal with interpreting the immune system based on a bunch of biomarkers measured in plasma, things are complicated and not fully understood yet. And human mind in general, and clinicians' mind in particular, we love simple relationships. The reason is that we need to justify our clinical decisions based on unequivocal data. And in the HIV field, we are very familiar with simple stories that have guided clinical management for decades, such as the association between CD4 depletion and AIDS events, or the HIV RNA levels and ART efficacy. And inflammation is one of these things that are more complicated. This is just an example, the Tnf signaling pathway. As you can see in the red circle, IL-6 is very downstream in the pathway and is only one among the dozens of effector molecules. And in addition, as you can see also in the right, IL-6 can be induced through other pathways. So the principle governing the immune system resembles more that of an ecosystem with interconnected and overlapping pathways, vectors, and so forth. So yet, we have very simple questions to be answered. For example, what are the patterns of inflammation driving adverse outcomes? What does mean having high IL-6 and low soluble CD14 versus the opposite. We don't know that yet, although we are starting to get information in this direction. In this big nested case control study in the US, IL-6, CRP, and IgG CMV avidity were predictive of type 1 myocardial infarction and deep vein thrombosis, which pathogenesis is affected by inflammation, but this was not the case of type 2 myocardial infarction, which is caused by vasospasm, different mechanism. So these kind of studies will help us better understand the patterns of inflammation linked with the different type of events. And we really need more evidence like this. And a very important idea, inflammation decreases sharply during the first year of ART, but once viral suppression is established, this decrease can be as small as a 1% change annually. So studies comparing ART strategies during the first year of treatment will have more power to detect differences between arms than those in a switch scenario, in which case we will need very long follow-ups. And we must keep in mind that a non-statistically significant p-value never rules out an effect. So always ask what was the power of the study when interpreting non-statistically significant comparisons. So observational data will be helpful to solve the puzzle because we need very long follow-ups. And also real-life settings can allow to compare the long-term changes on these inflammatory biomarkers in situations outside clinical trials where ART adherence is expected to be lower. So in this nested case control study, again in the Spanish CORIS cohort, we were able to compare patients who maintained 3 drug regimens versus those who switched to 2 drug regimens and had up to 8 years of follow-up. So we selected individuals who either maintained 3 drug regimens or switched to 2 drug regimens and had available stored plasma samples in the biobank and the longest follow-ups. And because in Spain, there are several groups that have been pioneered not only in ART simplification research, but also in ART simplification implementation, the general characteristics of both groups were comparable, and patients in the 3 drug regimen group do not show a significantly different clinical profile than those in the 2 drug regimen group. And while the pattern of inflammatory changes was similar during the first years of ART, in whom most patients were on 3 drug regimens, we observed a different trend after 3 years after virological suppression, which is represented here by the blue dashed lines. And this was, and we found in the 2 drug regimen group a significant increase of IL-6, CRP, and the dimers. And importantly, this decrease was not early, did not occur early. It was only appreciated after 2 to 3 years of ART switch, indicating that we will need to evaluate long periods before drawing firm conclusions on the differences on these therapeutic approaches on inflammation. And how big is the risk captured by the inflammatory biomarkers that show different trends in the studies mentioned before? There is only indirect evidence on this question, so we must be very cautious with the interpretations. And a way of translating this very indirect way is to talk about the effect size for clinical outcomes of inflammation in different settings. So if you look at IL-6 or the dimers, per each 2-fold increase, you got a 45 and a 23% greater risk of mortality. And there is a 5-fold higher risk for those with a CD4-CD ratio below 0.4. And these effect sizes are comparable to those reported in other studies for established risk factors such as hypertension, diabetes, or obesity. Another way to try to understand the scope of these differences is through mathematical modeling. And in this sense, we have developed a tool to better understand the potential clinical impact of the reported differences in the previously mentioned studies. And because IL-6 is the marker with more data indicating its prognostic significance, we focused on this biomarker, and we created a Markov model to translate these differences of higher IL-6 in the TANGO and the CORIS study in virologically suppressed people with HIV switching from 3 drug to 2 drug regimens to risk of clinical outcomes. Based on the previously IL-6 data, generated from the inside study group. So please, let's interpret this information fairly. This is a modeling study, and what does it tell us? It tells us that provided that our assumptions are correct, the reported differences on inflammatory biomarkers on IL-6 are clinically relevant. Unfortunately, we will need a huge study to test this clinically. We'll need nearly 3,000 participants in a 240-week study, randomizing patients to a regimen associated to higher and lower IL-6 to detect differences in clinical outcomes. And our last topic to cover refers to specific anti-inflammatory interventions. And before that, I'd like to simply comment on conceptual ideas. So strategies to prevent the consequences of inflammation, which are represented in this variant tree as the leaves, are the end organ diseases, should target the roots, which can be summarized as HIV reservoirs, inefficient CMV control, microbial translocation, and also the pathways, including inflammation, coagulation, and lymphocytosis, or maybe a number of them. So we definitely need to keep on doing proof of concept clinical trials as the best way to design next studies to see whether we can actually improve inflammation or not. And it has been at the beginning frustrating to see how many very candidate options such as aspirin or methotrexate failed to improve inflammation in HIV. A possible explanation why targeting the roots and pathways of inflammation have failed to show effects is maybe because the roots are multiple and may require combined strategies. But still, with this idea in mind, let me show you this data. We developed a nutritional supplement that was supposed to target many of the defects in the guts causally linked with inflammation among people with HIV. And we randomized late presenters starting ART to receive either a high dose of this supplement daily during 1 year or a placebo. So we found a dramatic improvement of many relevant biomarkers of immune activation and inflammation. And we realized also how ART is effective. And we were glad to have included a placebo group in this study because the improvement was similar in both groups and was mediated essentially by ART. We even didn't find changes at the microbiome composition level. So again, another strategy failing to demonstrate any effect at this level. But this field is now encouraged by several findings. First, it has been proved that reducing IL-6 results, IL-6 with canakinumab and IL-1 blocker decreases the incidence of cardiovascular events and lung cancer in patients with previous history of cardiovascular disease. And this study is a milestone in the inflammatory field because it allows establishing a causal link between inflammation and these events and a rationale to further explore these strategies. And next, some other interventions, including targeting the inflammatory response with anti-inflammatory agents such as dipyridamole, and also canakinumab or tocilizumab, or targeting CMV are showing promising results in terms of attenuating inflammation, but must still be assessed in more detail. So I previously mentioned other attempts to reduce inflammation by targeting the gut barrier or the microbiome have been unsuccessful, but I like also to devote just a minute to the microbiome because this is one of my areas of research. And we have performed a study that suggests that the gut microbiome might be a feasible target. So here we selected 3 stool donors from a large stool bank and these donors had the anti-inflammatory microbiome signatures that were interesting to be considered ideal donors for people with HIV. So we performed a placebo pilot control trial in which patients in the active arm received 8 capsulized fecal microbiota transplants over 8 weeks. And we found that this intervention attenuated the microbial signature associated to HIV and to inflammation and was able to improve one of the biomarkers that we measure, intestinal fatty acid binding protein, which denotes gut barrier integrity and is also predictor of mortality in treated HIV. So the recruitment of the REPRIEVE study is done and will become the largest trial in HIV history. And it will tell us whether statins are strategy able to reduce inflammation and clinical outcomes in HIV, regardless the absence of dyslipidemia. So I am optimistic in terms of the future pharmacological interventions to treat inflammation. But to be honest, the most efficacious anti-inflammatory interventions to improve health is likely the hardest to implement, and this is changing the lifestyle factors. So the anti-aging science is fascinating and has clearly showed that exercise, caloric restrictions, and perhaps some pharmacological interventions such as metformin can increase the lifespan. And we also have evidence that exercise is able to decrease very relevant markers of inflammation in HIV-infected patients. So to conclude, inflammation is detrimental in the long term and is linked and associated with non-AIDS events and non-mortality during ART, and is also linked to virological events that occur during ART-mediated suppression, likely in the lymph nodes. We have accessible and meaningful biomarkers such as C-reactive protein, IL-6, D-dimers, or the CD4-CD8 ratio. And in terms of treatment, patients will likely benefit most from intervention on traditional risk factors. Integrase inhibitors seem to perform better than other three-drug regimens, and difference between current two-drug versus three-drug regimens deserve further investigation. And more research is needed in general in this field. I really would like to encourage researchers to jump into this field because it's fascinating and has strong clinical implications. And with that, thank you very much for your attention, and I will be very happy to take questions.
I think you've given us a really interesting, wide-ranging, and comprehensive look at what is surely a complex and growing field. We are going to move on to the question and answers, and I think there aren't any Q&As that have come through so far. So I'd like to just encourage everyone to please put in your questions and click the send button. But maybe just as a way of getting to the discussions before the questions, we will be asking a few questions. And Dr. Serrano-Villar, I think what we'll do is we will go through the questions one by one. And as the votes come in, we will sort of take that as a launching pad for further discussions. So the first question that's going to go out is with regards to sources of inflammation, and which of the following are direct causes of inflammation amongst people living with HIV who are able to maintain viral suppression through ART? And the options are, as you can see on the screen, whether it's microbial translocation or the leaky gut barrier, asymptomatic CMV replication, or the expression of HIV proteins from infected cells in lymphoid tissue, or really all of the above. So maybe I think we'll just give a few seconds or a minute or so for people to put in their answers. Okay, so I think we've got a few responses already. Okay, I think let's see if we can get to a couple more responses. All right, I think let's sort of close this particular question here. So, Dr. Serrano-Villar, what do you think? I think you went through in the earlier part of your talk, the various sources of inflammation. And the main question I think I have at this point for you, Dr. Serrano, is how do you think we should specifically target this? And my main interest is with regards to sort of CMV replication. You mentioned in your talk multiple times that measuring all of the different either sources of inflammation or markers of inflammation can be quite complicated. And one of the terms that I really took away from your talk was this concept of the inflammatory soup. CMV replication, I think, is quite attractive as a simple marker, right? We can perhaps look at CMV viral load, PCRs, and what do you think about the specific therapy, preemptive therapy, for example, in people living with HIV to target this particular source of inflammation?
Yeah, that's thank you for the question, Dr. Wong. That's an interesting one. So actually, CMV replication, or not necessarily replication, because you can also have other ways to measure how our immune system controls CMV. You can do IgG avidity, or you can measure the cell-specific CMV responses. So that's been one of the targets that it's been shown to be associated with a decrease of inflammation. So when in a study led by Peter Hunt, they gave valganciclovir to patients, T cell activation, also some biomarkers of inflammation decreased. So the problem is that we, from a clinical perspective, we can't use valganciclovir because of the toxicity of this drug to measure an inflammatory marker that may be linked with improved prognosis really in the long term. So as far as I'm concerned, I know that there's an ongoing trial with letermovir, which is a more attractive compound, but I doubt that this will be a target per se in the future. Maybe we want to promote the specific immunity or to prevent further damage by diagnosing or earlier to our patients and putting them early on treatment, so that we will be preventing the immune damage that is associated with CMV ineffective control.
Okay, thanks very much. I think there are some questions coming in, but I think what we'll do is we'll try to go through the other poll questions first, because I think some of the questions that are coming in kind of take a more sort of holistic view of the topics and the issues that you brought up. So let's move on to the second question that is on the poll, and this is really with regards to biomarkers of inflammation. And so should inflammatory markers, for example, IL-6 and D-dimer, be monitored in people living with HIV who have a suppressed viral load to assist in clinical decision making? And the options are, as you can see on your screen. Yes, these markers strongly predict disease. No, since they fluctuate too much within individuals to predict disease risk for an individual patient. And no, since we lack validated cutoffs. Okay, I think we've got quite a good number of responses coming through. Majority are saying that we should not be monitoring these markers because we lack validated cutoffs and because they fluctuate too much within individuals to predict disease. So, Dr. Serrano-Villar, what do you think about these responses? Do you think that they reflect the general impression or the general sentiment of HIV physicians, who many of us are not really trained that well as immunologists, and our view on these inflammatory markers, I think, is something that is just growing in prominence? And I guess a related question that I have for you, Dr. Serrano-Villar, is, there's a lot of move towards sort of very individualized medicine nowadays, where we sort of look at the patient as an individual with a specific inflammatory profile or inflammasome, I suppose. Do you think that there's a role for us to look at all our patients, maybe screen them for a wide variety of inflammatory markers at the start of their disease, at the start of their treatment, pick out those that are maybe abnormal, and then track these through longitudinally over time? And for patient A, it may be IL-6. For patient B, it may be D-dimer. For patient C, it may be CRP. So that there's some kind of individualization. Or do you think that there's not enough data here? Do you think that's a research gap that we should be trying to answer?
Yeah, so I essentially agree with you on the audience. So today we can't advise to monitor these biomarkers, But it is also true that we know that we don't have enough information with the HIV viral load and the CD4 counts to predict the risk of clinical outcomes in our patients. So we really need to know how to leverage these biomarkers because they are informative. Actually, for some of them, such as CRP or the CD4-C ratio, we have suggested values, and even if they are variable within individuals, uh, uh, as far as I think about it, if you are measuring a biomarker for many years in your patients, and at some point you see that it starts to worsen, you may want to pay attention a bit more carefully to this patient, or maybe you will try to do preventive interventions or a diagnostic workup, things like that. So I really think we should learn how to exploit these biomarkers. And it's also true that we don't have rock solid evidence for all of our decisions in medicine. So we do many things that are outside the clinical guidelines, because clinical guidelines can always provide the whole evidence, the best degree of evidence to respond all our questions. So for now, I will say that we can't advise to monitor them, but definitely we need to learn how to do it to have more meaningful biomarkers beyond the CD4 counts and the viral load. And maybe, this personalized medicine should be able to teach us which biomarkers may work for which individuals.
Yeah. On a related point, you did mention in your talk about the utility of the CD4 CD8 ratio. But you did also sort of show on your slides that most guidelines and the evidence does seem to suggest that if people are virally suppressed and are immune reconstituted with a CD4 count more than 350 that is stable, that there really is no longer a clinical need to monitor the CD4. So do you think that, because we should be tracking the CD4 CD8 ratio even in our virally suppressed patients for a longer period of time, it's being that there is some utility, it's something that we are more used to looking at, and perhaps just accumulating a bit more data so that we can learn to use it as a marker of inflammation and perhaps a target of intervention somewhere down the line?
Yeah, I agree. I actually, one thing that I love from the CD4-CD ratio is that when you look at both parameters, the CD4 counts and the ratio, you may feel comfortable with patients above 500 CD4 counts, but then you realize that many patients maintain very high CD8 counts. And what we have learned is that these patients have increased immune senescence and increased risk of severe events. So the ratio is a way to fill this gap. I don't think it will inform us of everything that can happen to the patients, but at least it's a little bit more than measuring only the CD4 counts, which is, as you mentioned, something questionable in the suppressed patient today, above 350 CD4 counts.
Right. Thank you so much. Now we're going to move on to the third question, which is with regards to the effects on antiretroviral therapy. ART regimens have no differential effects on inflammatory biomarkers, provided that plasma HIV RNA levels remain undetectable or below 40 copies per mil. Is this true or false? So quite a simple question, whether it's true or false. Okay, we've got a fairly overwhelming majority of people saying false. Oh, no, true is coming up as well. Okay, I think we can maybe go on to the discussion for this particular point. And this is where I think I will go straight on to some of the questions that have come in from the audience members, because they all have to do with antiretroviral therapy. So maybe, Dr. Serrano-Villar, this is a related question coming from a member of the audience. There are now more long-acting antiretroviral therapy drugs under active research. Some of them are part of two-drug regimens. Some of them are part of three-drug regimens. So, how would you think the long-acting agents will have an impact on, the science around inflammation and inflammatory markers?
So, well, that's totally speculative because we don't have information, but theoretically, one should expect that if one of the reasons why treatments seem to behave differentially on these inflammatory biomarkers may be because of the adherence that they allow. So, in principle, every day, one patient with an oral regimen has a chance, has a peak and a drop of his levels, and he could be daily below the IC50. So in principle, with long-acting agents, if we are able to deliver them properly to our patients, this won't happen. And these problems with ART adherence that have been associated with spiking inflammatory biomarkers shouldn't happen. So I think we should see a better inflammatory outcomes with long-acting agents than with daily agents, essentially based on a better ART adherence.
Okay. So another question that's come in from the members of the audience are, while we're waiting for more long-term or concrete data on two-drug regimens versus three-drug regimens, as far as inflammation is concerned, would you encourage treating physicians to keep patients on three-drug regimens in the meantime, as opposed to, switching over to some of these two-drug regimens? Would you encourage treating physicians to continue giving people three-drug regimens as first line? Or do you think that, because of the effectiveness of two-drug regimens now, this is something that until we get more data, this shouldn't be part of the decision-making process? What are your thoughts, I think, on two-drug regimens in this respect?
Yeah, so my thinking about this is that the data so far point like it definitely is worth looking at these inflammation differences between treatments, but we don't have actually data enough to argue that we must, because I mean, if there was a consistent effect on these biomarkers across the studies, and that's something that I hope we will learn in a few time. I think we should actually recommend one treatment above the other if we are able to link these differences with outcomes. But so far, we don't have this information. So I think we still have to at least demand to see this information as maybe exploratory outcomes in clinical trials, as being doing for now in the last study. So I think we still have to get more information about this.
Okay, thanks so much. Now let's move on to the last question of the polling, and this is with regards to treatment of inflammation. Which of the following interventions have been shown to decrease inflammation in treated people living with HIV on ART in clinical trials? Early antiretroviral therapy as opposed to later ART initiation, aerobic exercise, aspirin, 1 and 2, or all of the above? I think we can look at the responses that are coming in. So a number of people are saying 1 and 2. Some of them are saying all of the above. And early antiretroviral therapy. Okay. All right, I think maybe in the interest of time, let's just see what Dr. Serrano-Villar has to say about these. What do you think, Dr. Serrano-Villar, with the responses that have come in from the members of the audience? Do you think we're kind of on the right track?
Yeah, I think so. So actually, early ART is associated with a faster improvement of inflammation, and this makes sense. And aerobic exercise has been proved although in uncontrolled studies, but is one of these interventions that seem to affect positively inflammation. Unfortunately, aspirin, which is such an easy and straightforward intervention, didn't work in a controlled trial. So, yeah.
Okay. Now, I think we are really coming to the end of our time. Thank you so much for taking all these questions and leading us in this discussion after your excellent overview on inflammation. Hopefully we can see each other in real life at some place soon and continue this discussion on this growing field. So thank you so much, Dr. Serrano-Villar, and thank you so much to members of our audience for your questions and for participating in the poll. Hopefully we've given you something to think about. Please do remember to fill in the evaluation form and the feedback form before you leave. And I do thank the organizers for arranging this lunchtime symposium on a topic that I think will be of growing importance as we manage people living with HIV growing older with effective antiretroviral therapy. So thank you so much, and I hope to see you soon. Thank you.
Thank you so much.